and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Aaron Boster, who will answer as many of your questions as he can for the next hour. Now I'm delighted to introduce him. Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related central nervous system inflammatory disorders. He decided to become a multiple sclerosis doctor at age 12 as he watched his uncle Mark suffer from the disease in an era before MS treatment was available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate school at Oberlin College. He earned his MD at the University of Cincinnati College of Medicine and completed an internal medicine and residency in neurology internship at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by multiple sclerosis. He has been a principal investigator in numerous clinical trials, trained numerous multiple sclerosis doctors and nurse practitioners, and published extensively in medical journals. He lectures to MS patients and providers worldwide with a mission to educate, energize, and empower people impacted by multiple sclerosis. He lives in Columbus, Ohio with his son, Maxwell. Dr. Boster, we're so pleased to have you join us once again for your help. We're so happy that you come to and do this every other month for us.
Yeah, I absolutely love it. Thank you very much for having me back. I'm delighted to be here.
So let me give people some directions in case people are new and they don't know the directions of how to ask their questions. So if you have a question or comment, you can ask it by using the Q&A button in the app, which also allows you to send your question anonymously if you choose. You can even ask your question live by raising your hand. And to do so, just click the raise hand button or press *9 if you're on the phone. I'll call on you, at which time, of course, you'll have to unmute to ask your question. So why don't we start? I'm going to turn this over to you.
Fantastic. So we'll start by looking in the Q&A, and I see anonymous attendee has provided a question, which I'll read out loud. Is it really necessary to get a brain MRI every year? Can this be stretched out to every 2 or 3 years if there's no new symptoms and current symptoms don't get worse? So anonymous attendee, that's a great question. And I really think that there's some things to unpack there. Why do we get an MRI? Well, when you're making a diagnosis of MS, an MRI is rather crucial to look for the spots, or we call them the lesions, in certain locations to help clarify the diagnosis. Once we have a diagnosis and hopefully started on a disease-modifying therapy, then the MRI takes on a new value. It's a different reason we do the MRI. When someone's on a disease-modifying therapy, there are really 3 things that we're looking at to make sure that we're doing the best that we can, that we're winning, that the medicine's working, etc. The most important is what they tell us. I mean, let's face it, anonymous attendee, you're a you expert. You know more about you than anyone else. And if I learn to listen carefully to you, I can learn a tremendous amount about how you're doing and whether or not you're failing the litmus test of life, God forbid, or whether there's new things going on, whether you're having attacks, etc. The second way that we learn about you is by our testing. So when the doctor runs you through the MS Olympics, we're really looking to see if there's been changes on your neurological examination. The third way is by the MRI. The MRI teaches us things that we don't learn based on what you tell us, and we don't learn based on what we see on exam. Now, your comment is rather interesting because I don't need an MRI when there are new symptoms. You're already giving me the information. But it's when things are going well clinically that I need the MRI. The value of an annual MRI is to look under the hood, so to speak, to make sure that we're not being duped, where you feel good, you look good, and yet we see new inflammatory disease activity telling us, oh my goodness gracious, we're not doing well. Do I think it's absolutely imperative that we get an MRI every year? No. Would it be my strong preference? Absolutely. If it has to be done every other year because of financial constraints or because of other constraints, that's the real world. But given my druthers, all things being equal, I want a picture of your brain once a year to make sure I'm not missing something. And I want to get a picture of your neck, the cervical spine MRI, at least every other year. That was an awesome question. Thank you for asking it.
That was. And we have another anonymous attendee question. How does general anesthesia impact MS symptoms? I was put under a couple of weeks ago, and I have just started feeling back to normal.
So according to the textbook, it doesn't matter, right? So technically speaking, having MS should have no bearing on general anesthesia. My anecdotal experience, however, is that my patients tend not to handle anesthesia as well as I would like. And it's not uncommon that it takes a hot minute before you kind of jump back in the game. So your comment is in keeping with what I've experienced clinically over the last 2 decades, that when my patient has a procedure, sometimes it takes a little while to recover from the anesthesia. Excellent question.
And so Judy wants to know, she's going to be switched from abagio to Vumerity. Why is an abagio cleanout necessary, and what are the repercussions of both drugs in your system?
So I can't answer, Judy, for you specifically because I don't have all the information about you, but I can give a general answer. So when you take abagio, which is teriflunomide, a pill that you take once a day, it has what we call a very long half-life. When you stop abagio, it takes 18 to 24 months to get it out of your system. And that's a really, really long time. Now, truth be told, I oftentimes switch someone without washing them out. Now, that's my clinical practice, and that doesn't make me right. That's just the way that I practice medicine. And presumably, your neurologist feels that it's safer to wash the drug out of your system. There are times, of course, when that's necessary. The most common example is when someone were to become pregnant and they're on abagio, and so we want to get the abagio out quickly. Now, the second part of your question, what are the ramifications of overlapping those 2 drugs? Well, there's some theoretical concerns. Both are processed by your liver. And so I can imagine that maybe your neurologist is concerned about stacking risk of liver, stuff like that. But really, the take home here is that when you make a transition from drug A to drug B, you have to consider both. And it sounds like your neurologist is trying to do the best they can to keep you safe, which I think is awesome.
Nice. And another anonymous attendee is saying, I've tested positive for JC virus. I've started Vumerity despite the small risk of PML. Is it necessary for me to take a blood work to check for lymphocyte count, etc.?
So the same caveats apply that I don't have your medical chart to give you exact information about you, but I can make a general comment. So the risk of PML is extremely low with Vumerity and with Tecfidera. And when I review the medical literature, the risk is really non-existent unless the white blood cell count is pushed down. You see, Tecfidera and Vumerity do not work via immunosuppression. That's not the way that the drugs are intended to work. However, about maybe 15 to 20% of the time, as a side effect, we'll see that the lymphocyte count goes down. If the lymphocyte goes down, if that count is low, then that person might be at slight risk of PML. So I think it is important to check a CBC with differentials so that I can look at the lymphocyte count. And as long as it's not low, I feel very comfortable. Now, do you need to keep doing it? That's a discussion point. When I look at the literature, the risk of dropping your lymphocyte count is really in the first 6 months. And so I really want to check it carefully in the first 6 months, and then I may get a blood test once or twice a year. Excellent question.
Sharon says if MRIs are stable for several years and secondary progressive MS is stable in her mid-60s, is it possible to go off of her GMT after 29 years of being on it?
So this is a very contentious topic amongst neurologists worldwide. And there are really 2 camps, if you will. Now, as a sidebar, I've made many, many YouTube videos about this exact question. And so I really appreciate you asking it. Some neurologists feel that as we age and as our immune system gets quieter, that the need to stay on a disease-modifying therapy is not necessary. and they may say that a patient so-called aged out. I am not in that camp, not at all. I think that it's critically important that you remain on disease-modifying therapy. And I do want to give a couple reasons why. The disease-modifying therapies, particularly the newer ones, do way more than just prevent attacks and prevent new spots on MRI. They slow down brain volume loss and they decrease risk of progression. Now, in research, when you stop disease-modifying therapies in folks that are 55, 65, around there, a third of them go on to have progression of disability. And if that 1/3 is my mom, I'm not okay with that. And so I am of the strong opinion that you want to keep on keeping on. Thank you for asking the question.
Okay, so this is Mark. He says, good evening, Dr. B. And first of all, thank you for being here. I have PPMS, NF, and type 1 diabetes. I won the genetic lottery, he says. My biggest issue is spasticity. I already have a baclofen pump, go to PT and do 1.5 to 2 hours of exercise daily. Anything else I can do, as this spasticity thing is just driving him crazy?
Mark, howdy, hi, and thank you very much for the warm welcome. As my mentor, Dr. Omar Khan, used to say, sometimes nature is a little too generous. Now, a couple thoughts. First of all, I want to make sure that the neurologist or the physiatrist is properly using the baclofen pump. All too often, it's my experience that someone has a baclofen pump implanted and they never are optimized, and that they're given very, very low doses. And so the first thing is I want to challenge the neurologist or the physical medicine doctor to crank that puppy up and really take on the full value of intrathecal baclofen. So that's my first comment. That stated, there are many other things that we can do to help spasticity. Let me give you a few examples. Baclofen pumps, which I love, do a bang-up job of helping with proximal limb. So if I can get my arm in view, they do a really good job here. They do a less good job at the end of the limb. So like the feet, the ankles, the hands. And it's not uncommon that when we use a baclofen pump, we then have to, quote, clean up with Botox. So I'm not talking about Botox to make you not have wrinkles and make you beautiful. And I'm not talking about Botox for migraines. I'm talking about Botox for spasticity. And I oftentimes find that using focal Botox to clean up after the baclofen pump is optimized is a really good idea. There's other things that we can do to help with spasticity. Just in the spirit of being sassy, if you are living in an area where medical cannabis is approved and available for an MS indication, I have had great success with patients using medical cannabis or just using CBD alone as an adjunctive therapy to help with spasticity. There's a lot more, and thank you for asking that question.
Thank you. That was good. Robert says, I was on Mavenclad. I finished my last of Mavenclad in January. Since then, I have been having like tremors and a bunch of weakness. What can I do to try to get more energy?
So I don't know that the Mavenclad comment is directly related to the I need more energy comment. And I want to explain what I mean. When we treat MS, there's really 3 types of treatment that we're doing all at the same time. The first is treating an attack, God forbid, when we have them, all right, which is outside the scope of this question. But if you have an attack, then we need to identify it and we need to give steroids and hasten recovery, right? The second thing that we need to do is we need to slow the disease down with disease-modifying therapies. And you give an example, one that you took, Mavenclad. And there's a bunch of different disease-modifying therapies available so far on this live stream. We've heard people talk about Vumerity. We've heard people talk about abagio. These are all examples of disease-modifying therapies. Those are birth control pills against future events, all right? They're intended to slow down the multiple sclerosis and help prevent attacks and new spots and slow disability. But there's a third category of treatment which must not be ignored, and that's treating symptoms. So symptoms are things that stink, right? And the most common symptom in multiple sclerosis is pathologic fatigue. It's the leading cause of loss of work of people impacted by MS. And it's also an invisible symptom, which is extremely frustrating because, honey, you look so good. You don't look sick. Well, you don't look ill-informed. And the reality is, despite the fact that the outward observer can't see this, the fact that you're exhausted, pathologic fatigue is devastating. So there are many, many, many things that you can do to help combat pathologic fatigue. And in the interest of time, I'll name 5 because I have 5 fingers on this hand. So one of them is you can make sure that you're getting a solid 8 hours of restorative sleep. Now, I chose that sentence carefully because I'm sure you sleep every night, but do you sleep 8 full hours? And are you getting restorative sleep? Do you have sleep apnea and you wake yourself up snoring? Do you have to get up multiple times to go to the bathroom and therefore you're interrupting your sleep? Do you have trouble falling asleep because of restless leg syndrome? Do you have spasticity, etc.? So really looking at the quality and the quantity of sleep is number 1. Number 2, cut out sugar. Now you might be like, what? But the reality is that we can massively improve fatigue by improving our diets. So avoiding fast food, avoiding sugar-laden food, avoiding fried food, avoiding heavily processed foods is paramount to having energy. And if you don't believe me, I double dog dare you to try it. Number 3, exercise. And you're going to say, well, Dr. B, did you just listen? I'm exhausted. I heard you, partner. But exercise is one of the most underappreciated tools for improving energy levels. Number 4, we need to critically look at your medicines and see if you're on medicines with good intentions that cause fatigue. For example, baclofen is a great medicine for spasticity, but it makes you tired. Elavil is a great medicine for headaches, but it makes you tired. Gabapentin is a great medicine for pain, but it makes you tired. And so we might need to go through your medication list and clean it up. Lastly, there are prescription medicines which massively help with energy levels. And many of my patients need to use medications like Provigil or Nuvigil, that's modafinil, things like that, or even stimulants like Adderall. And these can be very, very helpful in improving fatigue. Now, that's only 5 things. There's probably 20 more, but hopefully that gets you started.
Wonderful answer. So Ashley says that, and this is actually pretty cool, I never thought of this. She knows that smoking cigarettes can affect someone's MS. Does that apply to smoking medical marijuana as well? Because she knows that there's a few chemicals in medical marijuana.
So absolutely. I am a medical marijuana recommender in the great state of Ohio, but I do not recommend lighting it on fire and sucking in the smoke because that's super duper, ooper, smooper, pro-inflammatory. It's not just pro-inflammatory to your lungs, not just pro-inflammatory to your blood vessels, it's pro-inflammatory to the holiest of holies, the supercomputer that runs the body, your brain. And so whereas I do think that there's massive advantages to many symptoms by using cannabinoids, I don't recommend that you smoke them.
Okay, so we have a couple people with their hands up. I'm going to start with Jim. And Jim, I've just asked you to unmute, so go ahead if you can see that.
Yeah, can you hear me?
Yes, I can. Hey, Jim.
Hey, Doc. First off, love your videos, your YouTube stuff.
Thank you.
Thank you for being a participant with the Men with MS group, Matthew Price's group. Appreciate that.
Love that group. You guys are awesome.
Yes. How old is the printing press behind you? I digress. My question is concerning spasticity. And I am 20 years diagnosed. I go to see Doc Thrower tomorrow and get infusion number 117 of my baclofen. I mean, of my Tysabri. What I have is, when I think of spasticity, I think of constrictions of the muscles. Especially with my hands. I am was right side dominant. Now I'm left side weak. I will be holding something with my right hand and the hand just takes a notion to open and release. I drop stuff uncontrollably.
Yep.
Is that a spasticity? Does that fall into spasticity or control? Because when they did the evoked potential test, couple of years back, the signal going down, timing was good. The return path was delayed. Gotcha.
That printing press is well over 100 years old. So that's a platen press from turn of the century. And just so you can get a good view of it.
Nice.
It's a behemoth. I actually am really lucky. I recently identified a printer in Southern Ohio who's going to be coming to pick that up, so he can use it because I don't know how to use it. You're seeing one of my favorite MS neurologists in the country. I would submit to you that Ben Thrower is amongst top 10 MS neurologists in the United States. Ben's a friend of mine. I love that guy. So do me a favor, when you see him tomorrow, give him a hug from Aaron.
I'll do it.
You bring up a most excellent description. You're not a textbook, you're a human. And when you have an experience, it doesn't come with like a manual to tell you what happened. You're describing a situation where your hand misbehaves. And probably it's a multifactorial problem. There's probably more than one thing going on. You may have spasticity and weakness. Those are separate. So you can have some muscles that won't let go and other muscles that aren't strong.
I have both because I'll end up having to squeeze the hand like 4 or 5 times and hold it in a position to regain control over it. It's almost like the brain has lost control or knowing where it is in space and time. Same thing with my feet. My toes curl, but it's more predominant right now with my hand.
It's not even like that. That is actually what's happening. Now, the good news is there's ways around it. Now, so if you're seeing Dr. Thrower, then you're going to one of the best centers in the world in Atlanta, and they have some outstanding team members there. And so I want you to ask about seeing an occupational therapist. Occupational therapists are wizards. They look like normal humans, but they're not. They're wizards, and they help with upper extremity function and activities of daily living. And so if you're having trouble using your hand, they can either A, help you retrain it, or B, give you tools and tricks to help make it more successful. That was a great question. Remember to give Ben a hug for me tomorrow.
Okay, several years ago when I went through the bad exasperation, I did see the OT, so I will bring that up again. And to caveat on top of this, I do use Aaron out of Causes out of California. I do use the CBD at a 1-to-1 ratio, which does seem to assist to some degree. But
good. I love hearing that. Thank you for the question.
All right,
Thanks,
take
Jim.
care.
Bye-bye. So Judy said, I was told at my last thoracic MRI that it looked like someone went in with a paintbrush and left a general haze on my spinal cord. What can this mean for progression?
It's very hard for me to answer that question, Judy, because I can't see your MRI. I'm not going to be able to provide much of an answer beyond guessing at what that might look like. I will share that spinal cord lesions, so damage to the cervical spinal cord or the thoracic spinal cord, increase risk of progression of disability. But I'm going to have to stop my answer there because I can't see the scan.
Okay. And Larissa's saying, we think the first attack my husband has or had was in 2011 when he was 56. It went undiagnosed until October 2022, SPMS. He is now 68. He has difficulty walking, tires easily, and in the last month or two, his hip and knee joints started hurting. He is going to physical therapy, and I suspect the joint pain is a result of his gait being off for the last 4 to 5 years steadily. Let's see. Worsening, but want your thoughts on why his joints hurt now and what can be done about the pain.
Absolutely. I'm going to try to show off an example of MS walking so that I can explain it. So I don't know if this is going to work, but let's try, all right, because we're on film. So I'm going to move the chair out of the way, and we're going to mimic left-sided weakness. Okay, so I'm going to imitate, I'm not trying to be disrespectful, left-sided weakness, where the left side is weak. So if the left side's weak, then I may be walking a bit unusual. Okay, so I have a hitch in my giddy up, and you notice that I have to lift my left side and throw my leg over. Think about what that does to the good leg. All right, I'm going to do that again, and this time I just want you to watch the right side, the good leg. Okay, so I'm going to do that again. All right, so as I'm walking, look at how much I'm adding pressure to the good side. I'm using the good side in a way it was not intended to be used. Very commonly, my patients will have significant joint issues on the good leg because they're twisting it and they're putting pressure on it in a different way. And so my concern is exactly what you're suggesting, that because of the way that your husband is forced to walk, he's beating up on his joints.
Okay. And I know you touched on this before, but Lori has said that she's 67 years old. Her neuro says that she doesn't think, or he doesn't think that the GMTs will help her. Is this true?
No.
Okay. Good answer. Okay. How about let's take somebody else who has a question. H, I don't know what your first name is, but your last name is Jones. I'm going to ask you to unmute yourself. Go ahead if you can talk.
Howdy.
Hi. Can you
I
hear
can
me?
hear you.
Can.
Oh, pardon me. I typed my question into the thing, but I'll try to gather my thoughts quickly. My question is, how often do you see brachial neuritis in MS patients? In the past few months, I've had bilateral pain, spasticity. Sometimes it's dull pain, sometimes it's shooting pain, all the way down to the hands, especially the left hand with numbness and tingling. I've met with an orthopedic thoroughly in the beginning to exclude all of that. So ultimately, yeah, what are your thoughts on that, and how often do you see that?
So sometimes nature is too generous, and you can have MS and you can have a peripheral nerve problem. So the brachial plexus is a bunch of nerves that come off the spinal cord through the shoulder and they run the arm. And there are situations where you can have issues there. It's not very common that someone with MS also has that, but it can occur. And fortunately, there are some things that we can do about it. I will share that someone with MS can have similar symptoms because of spinal cord damage, and if you have slipped discs or arthritis in those areas, you can pinch on those nerves. So I wish you the best of luck. And if that's a picture of your dog, boy, your dog is really, really cute.
Thank you. Yeah, the disc stuff had been eliminated too, unfortunately, and no new spinal cord lesions either. So it's just kind of at a loss with not being able to find the actual solution other than just, masking the pain or, taking something for it.
You might want to see a neurologist who specializes in peripheral neurology. So a neuromuscular doctor and or a physical medicine doctor. Best of luck to you.
Thank you.
Thank you. Bye. So Angie said, what DMT do you suggest for SPMS patients with no active lesions but progression? I've used Tecfidera, Gilenya, and a whack-a-mole treatment of Lemtrada and Rituxan, which ended in 2016. No DMT since. Thank you.
So this is a tough one without having more information, but off the cuff, when I look at that list, I'd put you back on rituximab. I think that B-cell depletion has some of the best data for what we call PURA, progression independent from relapse activity. We're working diligently to develop therapies with a focus on progression. And right now, I have a tremendous amount of excitement surrounding routine tyrosine kinase inhibitors, or BTK inhibitors. And it's our hope that they may be able to help with this smoldering multiple sclerosis that you're talking about.
Great. And Dakota, I'm going to allow you to talk so you can ask your question.
Hello.
Howdy.
Hi, my question is, I don't know, I think you kind of answered with your hands, but does an unhealthy diet causes more MS flare-ups?
So that's a wonderful question. I love that question. So it's my strong opinion that you can impact your MS through what you eat. And I'm continually impressed that when people clean up their diet, their MS symptoms improve. Now, I don't have data to prove to me that we can decrease attacks through diet, but I feel very, very strongly that by cleaning up your diet, you can improve energy, you can improve mood, you can improve thinking and memory, you can improve many, many symptoms in MS. And so I always like to start by upping your water game. I want men to be drinking about 120 ounces of water a day. I want women to be drinking at least 100 ounces of water a day. I want people to increase their vitamin D3 through supervision of their neurologist to get that level up. And I want you to remove processed foods. I've made a lot of YouTube videos on this topic because I think nutrition is super important. So thank you for asking that question, Dakota.
Okay, and Leslie, I believe that you should go and raise your hand because you didn't really finish your question. So rather than ignore it completely, I'd rather you ask him personally that question. But Linda said, what do you think about the trial going on about going off DMTs if stable and older?
I think it's a terrible, terrible thing. I think that many neurologists have an illness called ageism, and I think it's a terrible decision. I do not agree with it whatsoever.
Okay. An anonymous attendee says, I was diagnosed recently with diabetes, considering my glucose was always normal before my MS diagnosis. And I drastically changed my eating habits for the better in the last year since being diagnosed with MS. This came as a huge surprise. My doc said it could very likely be because of the high dose steroids for treating the MS in the very beginning. How common is this in MS patients? And is there a medication that is better to help lower my glucose while having MS and being on Kesimpta? My doc has mentioned Ozempic and metformin as options. MS, the gift that keeps on giving.
So if you have one autoimmune condition, and MS is the example, you are much more likely to suffer a second autoimmune condition. And that may be the kind of situation that we're in. Again, it's the third time today that I've said a quote from my mentor, sometimes nature is too generous. Now, it's true that constant exposure to steroids can make glucose regulation messed up. And so I think that may be a contributor. Ozempic is a medicine which helps with weight loss. It's become very popular and it's very effective, and I think it's safe in MS. Metformin is a medication which can be used to manage type 2 diabetes. And interestingly, there's a small literature suggesting it might be helpful as a neuroprotective agent. So I do think there's a lot of things that you can do. Kesimpta, which is a self-injection of a B-cell depleter, does not elevate sugar levels, and there's no steroids associated with it. And so that might be a really good option for you. Best of luck.
Thank you. Charlie from Facebook asks that this week, MS News Today posted an article about research supporting inclusion of optic nerve in McDonald criteria for MS. I have RRMS, but I've never had optic neuritis. Is it normal to have RRMS, but never optic neuritis?
Yes, it's not a requirement that you have optic neuritis to have relapsing MS. Now, what they're talking about is a little bit different. So let me explain. Back in the ancient days of yesteryear, circa 1980, the way that we would diagnose MS is someone would have an attack, and then at some later time, they had a second attack. And what we found was if we use that newfangled thing called the MRI, we can diagnose MS faster. So you have the first attack, and then you could have an MRI that met certain criteria, and you could diagnose before the second attack. And that came out around 2001. And then with each further update to the criteria, 2005, 2017, we were able to use the MRI more and more effectively. Most recently in 2017, when we revised the McDonald criteria, you could have one attack, and then with one MRI, you could diagnose MS, but they excluded the optic nerves. And so now they're revisiting that. But that is not to say that you have to have optic nerve involvement. What it's trying to do is it's trying to help us be accurate in the diagnosis as early as possible. But The short answer is no. You don't have to have optic neuritis to be diagnosed with relapsing MS.
And Jennifer says, does numbness gradually get worse? It started 3 years ago in my little toe, past all toes, now going up to my calf, worried that her legs won't work eventually.
So it's not a requirement that numbness gets worse, and language is very important. So when you say the word numbness, what I mean by numbness is a change in sensation, which has nothing to do with the way that it moves. So you could have a numb toe or a numb leg and still be able to move it completely. You can see progression of neurological symptoms. And sometimes if you have a spinal cord injury or a lesion from MS in a spinal cord situation, then you can have a worsening over time. Now, this is absolutely something that I want you to talk to your neurologist about, because there are things that we can do to intervene. Thank you for that question.
Okay, and Naomi, I'm going to let you talk and ask your question. So go ahead.
Howdy.
Hi, can you hear me?
Yes.
Hi, thanks so much. So I hope I'm not being an interloper here because I have not officially been diagnosed with MS. It's something that I only recently started to suspect. Long story short, I've had for 20 years, I've been fatigued, chronic pain. I've had weird falls. I have double vision. I have weird symptoms like feeling things are wet, just all this sort of stuff. And I had no idea what was going on. I've been diagnosed with fibromyalgia and with rheumatoid arthritis and these other things, but I kept trying to kind of figure out what else was going on that could explain these other weird symptoms. And I did have a recent MRI, but it wasn't with contrast. It was like a without contrast dye MRI. And the neurologist was sort of dismissive and just said, oh yeah, it looks great. And I didn't really know what to tell him to look for. I suppose my question is to get a positive diagnosis of MS, do you need to have an MRI with contrast and or a spinal tap? And then my other question is if it's not MS, are there other, I know there's tons of autoimmune diseases, but is there something else that comes to mind that's sort of similar to MS that mimics a lot of this, what I think of as sort of more bizarre symptoms like the sort of phantom wetness and double vision and things like that can't be explained by things, I know it's not Hashimoto's, I know it's not Sjogren's, but something like that.
So you give a good example of the fact that you're not a textbook, you're a human being, and you have a lot of symptoms, and a lot of them sound just awful, and you're not given a manual as to why. And so I view a situation like this as something which merits a workup for possible diagnoses, and we have to have a very, very open mind about all the different things it could be. So MS is not a feeling. MS is not like something that you smell. MS has very, very clear diagnostic criteria. And just to summarize briefly, there's 5 elements to an MS diagnosis. The first is to take a careful history. And so you list a lot of symptoms that can be seen in the setting of MS, but it does not mean that you have MS. And so listening very carefully, an MS neurologist can help tease that apart and see if those symptoms make sense with MS or maybe a different condition. The second thing that we look at is we look at the neurological examination. And in essence, we're looking to see if we can find evidence on the exam that support the story and would suggest MS or not. The third thing are the MRIs. And to be comprehensive, we need an MRI of the brain, cervical, and thoracic spine. Do we have to have contrast? No. Does contrast help? Yes. The fourth thing is a lumbar puncture. It's not required, but it can be very, very helpful. And number 5, which is critically important, is, hey, Aaron, prove it's nothing else. And so to answer your second question, there are myriad things that can cause those symptoms. If I started to write things that can cause those symptoms at the top of that wall, I would be going all the way to the floor and I wouldn't be done listing them. And so my best suggestion is to document very carefully what's going on and to sit with an MS neurologist who is fellowship trained to try to help sort through it. And best of luck to you, Naomi. Thank you for the question.
Thank you.
So Linda said, what is your impression of Mavenclad for older patients? Some call it like an exit plan treatment because you may be done after a few years.
Now, the very first time I heard about this so-called exit strategy for Mavenclad, I was offended. I said, what do you mean an exit strategy? That sounds disrespectful, like you're dismissing patients. This was really first suggested by this really cool neurologist up in Canada. And I'll tell you what, I love it. I love it. And I do it a lot. Mavenclad is a micro-induction therapy where you take 5 pills the first month, 5 pills the second month, and you're done for the year. That's 10 pills the first year. Then the second year, you take 5 pills the first month, 5 pills the second month, and then you're done being treated unless you have new disease activity. So very commonly, I think it's awesome sauce to give someone, I'll just say hypothetically like a 63-year-old, these kind of medicine, and then we find that they may not need to be treated again. I don't like the term exit strategy because I think it gives an impression that we're done taking care of the human, which we're not. But I think as far as a disease-modifying therapy, it's a lovely option. And I've actually made a couple YouTube videos exactly on that topic. Great question.
Awesome. I can't read the full name on this, but it's Larris. That's who's asking the question. My husband just started Ocrevus, first set of infusions in April. How long before we should check to see if there is still progression or further lesions? And how soon should we go back to our neurologist?
So this gets into the style of medicine, and I don't know the way that your neurologist practices, but I can share with you at least my experience. So whenever I start a patient on a new disease-modifying therapy, Ocrevus is an example, I check new baseline MRIs 6 months later. Now, I chose my words carefully. These are re-baseline MRIs. And so what I'm doing is I'm calling into scripture, hey, you've been on the medicine for 6 months. Let's take a look at the pictures and see kind of where we are. And this is the new baseline as we move forward. I also think that patients are best served by being seen quarterly, so every 3 months. And when we see them, we need to listen. Are they failing the litmus test of life? Are they having events? Are they getting worse? And we need to examine them or do some type of functional testing. And so I think over the course of the next year, you're going to get the best sense of if we're controlling the disease or not. Excellent question. And I wish you and your husband the very best of luck.
Elisa from Facebook is asking, is there a cure for cerebellar tremors besides deep brain stimulation? I have not written anything in 10 years because of it.
So cerebellar, so the cerebellum is, that's the Greek for little brain, all right? And it's a structure in the base of the brain, and it's a control center for movement. So if you think about, like, if I want to take my finger and I want to, bam, hit this, in order to do that accurately, I use my cerebellum. And if my cerebellum is damaged because of bourbon, or if my cerebellum is damaged because of MS lesions, what we may find is something called ataxia, where I have trouble making it go like that. And as you point out, cerebellar tremors are very, very hard to treat. It's absolutely true. And it's very, very frustrating. There is no pill for that ill. You can sometimes have excellent benefits from working with an occupational therapist. It is true that using deep brain stimulation for some types of tremor can help. Another thing that I sometimes have success with is a weighted bracelet. So imagine a bracelet that's 10 pounds or 3 pounds, probably 10 pounds is too much, say 3 pounds, and it weights the arm down and it kind of cuts down on the degree of tremor. There are some really cool devices out there that occupational therapists can turn you in on. One that I like a lot are these really cool spoons. And as you shake, the spoon moves against it. And so ultimately it keeps the spoon stable. And so someone that would otherwise really struggle to be able to feed themselves is able to do so. But to your point, cerebellar injury is very, very difficult to treat.
Thank you. Joe's asking if copay funding is difficult for MSers on Medicare. Why is this? And do you know of any changes coming down the pike anytime soon? So many people are going without their meds because they can't afford their copays. There is zero funding right now for anyone on Medicare.
This is a super tough one. And I certainly don't want to piss off the American government, but I'm going to point out something which is frustrating. If a human being has non-government insurance, then oftentimes the manufacturer can provide what we call copay assistance, and they'll essentially cover all or part of the copay. But if you have government insurance, and so Medicare is an example, Medicaid is an example, then you're not allowed to participate in copay assistance from the manufacturer, which really doesn't make a lot of sense to me. That's very, very frustrating. Now, there are organizations like NORD, which can sometimes have funding, but as you point out, they're used up very, very quickly. And so that can create a situation like you're talking about where it's very difficult. However, there are ways around this in some respects. I made a YouTube video on ways that you can get MS drugs cheap, and I'll give you just a quick example. So a medicine that I'm fond of is called abagio, that's teriflutamide, and abagio can be very expensive. But there is a prodrug which was initially created for rheumatoid arthritis. This is off-label, called Arava. And when you take Arava and you swallow it, the first metabolite is abagio. Arava is generic, and with good RX coupons, it's about $8 to $20 a month. And very oftentimes when my patient's having difficulty with access, we may go that route. There's other things that can be done, and you can check out my YouTube video on the topic, but you're touching on something which is very, very challenging. And oftentimes, if you work with an MS neurologist, they'll have some tricks and tips and things like I just shared, which might help make medicines available to you. Another thing to consider is whether or not there might be a clinical trial that's available for you where there's no placebo. So if you participate in a clinical trial where you're either on drug A or drug B, and they're both real drugs, and you just don't know which one, for some patients, that's a really great option. Best of luck to you, and thank you for bringing that up.
Great information. And Doc, you have no idea how many people every day call the Multiple Sclerosis Foundation about the same exact thing. So I'm going to refer them to listen to this and to your video. So I'm going to let Mary talk and ask her question. Go ahead, Mary. If you're still there.
Howdy, Mary.
Well, let's see. Mary. Nope, I guess not. Let's take her off. I'm going to allow you. No, I guess she's gone. Okay, so Srivida said, hello, doctor, I'm experiencing new symptoms like tinnitus in one ear, vertigo, nausea since June. I was put on steroids, no signs of any inner ear infection or hearing loss as per my ENT. Can these be caused by MS lesions?
Yes, they can.
Okay. We have another anonymous. I have been on Gabapentin 900 milligrams for tingling and numbness since October. The numbness improved, but the tingling is constant from the waist down. What else can be done?
You bring up a really important point. Medicines like Gabapentin, which were initially invented to treat seizures, can sometimes do an outstanding job of helping with certain abnormal sensations, in particular, painful sensations. But the medicines are less effective at treating numbness and tingling. Now, the neuro word for numbness and tingling is paresthesia. And based on your question, some of the paresthesias are responding and some of them aren't. Now, there are probably 20 medicines that I can think of that can treat paresthesias, Gabapentin being one of them, but it's a really kind of trial and error sort of situation. It is possible that we might not stumble on exactly the right one, but I think it's worth the fight. And if Gabapentin's not working, we can try going up on the dose, or we can switch to a different medicine in hopes that using a different mechanism may help.
And Stephanie says, Mark Cuban, something about Cost Plus offers MS medications that are discounted. That's great.
That's right. And so that's another tool, kind of like I was sharing with GoodRx, where you can sometimes get a hold of MS medicines at a reduced cost. Excellent point.
An anonymous attendee says, in an effort to stop drinking soda and other unhealthy beverages, I started drinking a flavored water called Circle. I need some flavor in my water in the mornings. Since I started drinking Circle, I have not craved or drank a soda at all. The majority of the flavors have sucralose. Is sucralose terrible for people with MS?
Is it terrible? I don't think it's terrible, but it's not very good for your gut microbiome. So these artificial sweeteners just devastate the gut flora, the microbiome. Do I think that's terrible? No, I don't. You know what you might try to do is you might try to look for a couple other flavoring options. And I wonder if you took just straight out water and squeezed lemon or lime into it, like actual lemon juice or lime juice, whether that would provide a flavor without the risks of the artificial sweetener.
And Drew says he's a professional drummer, and as you'd imagine, would love to continue. Because I'm very interested in the research happening now in RE to a cure and disease modification, any encouraging work being done with stem cells. Also, my brilliant neuro has me on metformin in hopes of remyelination. METF has long-term side effects. Is it worth it?
So I am glad that you're a drummer, and I want you to keep on drumming. And I think it's important that we don't allow MS to make decisions for us. And so that's a packed full of information question. One of the things you asked, is there encouraging work being done in stem cell transplantation? Yes, there is. There's a lot of ongoing research looking at stem cell transplantation. I don't think stem cell transplantation is a holy grail. I don't think it's magic, and I don't think that it will cure the disease. I do want to share with you that internationally, there are massive, massive efforts going on. Some of them were participating at the Boster Center for MS, trying to find remyelinating agents and neuroprotective agents, and agents that work to help decrease smoldering MS and progression of disability. And so the future is very, very bright. Keep on drumming.
Thank you. I'm going to let Dale ask her question. So let's unmute you. Go ahead, Dale.
Howdy, Dale.
Whoops, I think we have Robert. I think I must have done both, and somehow, Robert, go ahead and ask your question. I'm just going to tell everybody we have to make it a little quick because we have a lot of questions, and we have very little time left. So
yes, I was wondering about the optic neuritis that I have. Is there anything I can do on my side to help cure that?
Hey, Dale. Oh, no, this is Robert. I'm sorry. Hey, Robert. So there is, when someone has an early optic neuritis, when it just happens for the first time, steroids can help it get better. And there's a very interesting paper that steroids and Dilantin, which is a seizure medicine, can help it get more better. If you've had a long-standing optic neuritis, I don't know an easy way to reverse it. I do feel that taking disease-modifying therapies can protect the other optic nerve. But right now, I don't know a way that we can reverse permanent damage from optic neuritis if it's been there for quite some time.
Yeah, I had it for like 2 years now.
So I think it may, if you have the symptoms and you have vision loss 2 years out, my concern is that it may not bounce back. And we want to do everything known to God and man to protect the other eye. And so being on a DMT and making sure that we have good eye health is very, very important. And good luck.
Thank you so much.
thank you, David. Okay, so I'm going to try to unmute Dale.
I'm still here.
Oh, good.
Hey, Dale.
Hi. How are you today, Doc?
I'm doing great. It's good to be here with you.
I'm finally glad to get through to you.
You're on.
Okay, my question is, how often do you deal with people with MS? And here's a good one, complex regional pain syndrome.
So CRPS, complex regional pain syndrome, is a nasty, nasty creature where
Yes,
oftentimes someone has a physical trauma and the pain doesn't go away and it actually gets worse. And long after the trauma, they can be left with excruciating pain. It's something that I'm academically interested in, and I've dealt with it quite a bit. And I have found that there can be some benefits to things like intrathecal prealt, which is a pump that's implanted in the body, and then this weird snail venom that we give people. And so I've managed some MS patients that have CRPS with intrathecal prealt. I also have had some success using spinal cord stimulation to manage that. I think that working with a pain doctor, working with a physiatrist or a neurologist with an interest in CRPS is your best bet, and best of luck to you.
Thank you. So Bev said, I am on Ocrevus and have UTI. Will it not go away? Been through 3 antibiotics specific to the urine culture. What should I do? I don't want to end. I don't
Septic.
want, thank you. She doesn't want to end up septic in the hospital. So
people impacted by MS have an increased risk of urinary tract infections, and some people on Ocrevus have a further increased risk of urinary tract infections. There are many things that we can do. I oftentimes, when someone's having recurrent urinary tract infections, I will put them on a prophylactic antibiotic, something like Macrobid that they take every day. And this can cut down on the urinary tract infections. We also need to study the bladder. And if we have bladder retention, then we need to take medicines or catheterization or something to help treat that bladder retention. It doesn't mean that you're going to end up septic, but I do think that it's a very important thing to look at. And I'm glad that you're doing that. Work with your neurologist, work with your primary care doctor. And then when you can get into the urologist, we definitely want that expert help.
thank you. Jessica said when they work out, even with their cooling gear, they get extremely weak and shaky. Is that spasticity or is that nerve fatigue? Thanks for helping us all understand this crazy stuff.
So, Jesse, that's a great question. And what it sounds like is neither. It sounds like motor fatigue and heat sensitivity. When you have a damaged spinal cord or brain, and when you heat up the system, it can short circuit. And I'll give you a pro tip: exercise in water. So if you're doing water Zumba or swimming or even just walking in water, the water wicks away the heat off your body. And sometimes it can allow you to exercise and keep you cool so that you can get a lot more done. There's also a medicine called Ampera, 4-aminopyridine, which is not for every patient, but amongst those who respond, when they get overheated, they don't short circuit like that. And so you may talk to your neurologist about taking Ampera.
Thank you. Can an occupational therapist help with curled toes? My podiatrist says there is nothing to be done but wearing a crescent pad.
So fortunately, your podiatrist is dead wrong, and there's a lot of things that can be done to help curling toes. I'm not sure the occupational therapist is the best bet, but sometimes working with a physical therapist can be helpful, and working with a spasticity doctor can be very, very helpful. So we can actually pretend this is my foot, not my hand, because I can't drag my foot all the way up here. But the muscles that work on the toes are actually in the sole of the foot, and you can Botox those and you can get them to go straight.
Okay. By the way, Stephanie wants everybody to know that Mark Cuban has dimethyl fumarate,
That's Tecfidera.
and teriflunomide.
So he's saying that Mark Cuban with the discounts can have
Yes.
Gilenya, Tecfidera, and Abagio.
Yep, Impura, yes. That's great. So someone was told that there is no progression on their MRI, but yet they've developed new symptoms of
allodynia.
Yep, and shooting nerve pain. My skin hurts so bad that no one can touch me. Even my clothing touching my skin hurts like a sunburn. Is it possible that there are some changes happening in my brain that aren't being detected in the MRI? With this being a new symptom, should I consider switching to a different DMT rather? I'm currently on Kesimpta.
So you don't need to have new lesions to have worsening of old symptoms, unfortunately, because the old lesions can wear out. And I wouldn't per se immediately think about switching off Kesimpta. I would think about treating the allodynia. And there's a lot of allodynia is a doctor word for normal touch hurts. It's terrible. It's a form of neuropathic pain. And there's a bunch of different things that can be done about it. Medicines like we talked about earlier during the live stream, like Gabapentin, Neurontin is one example. I also have a lot of success using pain creams, and you can sometimes have benefit with allodynia using CBD cream. And so I would consider multiple different options to try to ameliorate that. Absolutely.
I recently had an MRI which showed no lesions and therefore was judged to be NBE negative. However, it was done without contrast dye. And I think, did someone ask this already live? I don't know. Well, anyway, without contrast dye, and the neurologist spent no time whatsoever going over it with me, but instead recommended an antidepressant. I am 42 and have been suffering from MS-like symptoms for over 15 years, including chronic fatigue, rheumatoid arthritis,
Yep. We did have this question. So neurologists are like plumbers, and if you don't get along with one, you go see another one.
Yeah, I like that answer. Psionic sleeve or E-stem. Have you seen it help MS patients build stronger muscles?
So the psionic sleeve is the newest, latest, and greatest. It's literally what it sounds like. It's a sleeve that you put over the leg, and it can help stimulate the muscles to work better. E-stem is along the same lines. Have I seen it help build muscle? Somewhat. I've seen it help with gait mechanics. It typically requires a really smart neurophysical therapist to help you dial it in. Is it a cure-all? Absolutely not. Can it be really helpful for some patients? Yes, it can. Great question.
Okay. Do we have time, or do you have time for me to answer just a couple questions extra? We'll go a couple minutes
Sure.
over.
Yeah, let's just go a little bit longer.
Okay.
Maybe like 5 minutes.
Gotcha. Thank you for that. Any idea when the new MRI dye will be available? Not the gadolinium.
Gadolinium.
Thank you. That I'm allergic to.
So I don't have information about that. I'm not going to make something up on a live stream. I don't know when that will be out.
Ms. Coleman said, hi, I've had MS since 1997. I can no longer feel my lower legs and feet, but can still move around with a rollator. What can be done to get feeling back? One neurologist told me after my last attack, I'd never feel my feet again.
So if you have a neurological deficit that goes on for about a year after the attack, I think there's a high likelihood that it may not return. And you give a really good example of the fact that sensation is different than strength. And so you might be able to move your feet, but not feel them. Now we have to be very cautious when we do this, because you can bang your feet up and get cuts and scrapes, which can get infected and you can't feel it. So every night you need to visually look at your feet, look at the soles of your feet, make sure that your foot health is intact. And if you have a bruise or a bump or a cut, we have to be very aggressive about treating that.
Honey would like to know, do you support HSCT in Mexico? Not for me, not interested, but my PPMS friend went a couple years ago and has had nothing but rapid progression and lengthy hospital stays. What are your thoughts on must be Ampera
and eating schedule? So I do not support stem cell tourism. So I do not recommend having a stem cell transplant outside of a controlled clinical trial. That's my opinion.
Okay. Caroline said, have you switched any of your patients from Zeposia to Ocrevus, and under what conditions would that occur?
So Zeposia is a Gilenya Me-Too drug. It's an S1P1 receptor. It's a daily pill. And it's so Zeposia, Ponvory, Mayzent, and Gilenya are all in the same class. And I consider those mid-range drugs from an efficacy standpoint. I think Ocrevus is a top tier drug. It's a B-cell depleter. So Ocrevus, Briumvi, Kesimpta, I think as a category are more efficacious. And so I have frequently done exactly what you're suggesting.
Okay. Tawana is asking, is Gabapentin or pregabalin? Oh, better?
So Gabapentin is Neurontin and pregabalin is Lyrica. They're both invented as seizure medicines, and they both work for neuropathic pain. And some people respond to one and some people respond to the other. So the answer is dependent on how you as a human being respond. We're not smart enough to know ahead of time who's going to do better with one or the other. And so we have to try them out.
Okay. Elise from Facebook is asking, can you talk about the new studies talked about at the last ACTRIMS conference regarding clemastine in showing demyelination of myelin sheath?
So clemastine is a medicine that's available for allergies. It's an antihistamine type medication, and it's got some of the most hopeful research for remyelination. It's still in experimental areas. It's still in research, but we really are hopeful that this might be one of the first drugs to hit for remyelination. I don't have any updates since that Congress.
Okay. Let's see, internal tremors. This symptom has been very perplexing and is also been ignored by my PCP and my neuro. Essentially, I will randomly feel like I am shaking, but I'll look at my extremities and I'm not shaking externally. Is this a thing?
Yeah, it's a thing. What's causing it, I don't exactly know, but we have to keep in mind that when normal sensory information is going up the nerve and gets to the spinal cord, it can get befuddled. And so the message that goes to the brain can be wackadoodle. And you may be feeling pain, you may be feeling itching, you may be feeling a sense of tremor, and it's not there. But you're not making it up, and it's very, very annoying. I don't think that's cray-cray. I hear that a lot.
Okay, this will be our last question, Doc. Thoughts on too much steroids and osteoporosis?
So people impacted by MS, boys and girls over the age of 50, and 50 is not old, have a risk of accelerated bone loss, osteopenia, and osteoporosis. And if you have extensive exposure to steroids, it can make it faster. And so that's something that we have to be very, very careful about. It's my strong opinion and the recommendation of most MS neurologists that after the age of 50, men and women with MS both need to have a bone density DEXA scan once a year, or excuse me, once every couple of years to make sure that our bones are adequate. We don't want to give out steroids airy-fairy just whenever because of that risk. And so that's a great question. Taking calcium, taking vitamin D, taking K2, and if you're able to walk, stomping the ground by walking and bearing weight, we can help strengthen bones.
Thank you, thank you. So I guess you've been very kind and gone over our time limit, but for those people that have missed the opportunity to actually have your questions answered, Dr. Boster is going to be doing this again in another month, not next month, but the month after. So you can come back and ask that then. So this brings us.
Before we go, Deb, somebody wants to say hi.
Oh, okay.
This is the most beautiful baby doggy in the whole world.
Aww.
This is my American Mastiff, River. River, say hi to the internet. She was just sleeping down here being calm and wonderful. You want to say hi to the interwebs?
Can you just tell us?
Thank you very much for inviting me.
How much? Wait, how much does that dog weigh? That's what we want.
180 pounds of love.
And how many cups of food a day does that dog eat?
Oh, we don't count that. We don't count that. Deb, thank you very much. MS Foundation is one of my most favorite organizations. The fact that you do this on a monthly basis, I think is a godsend. I'm grateful that I get to participate. So until 2 months from now, thank you very, very much. And I look forward to seeing you soon. And so does my dog, River. Bye-bye.
So that brings us to the end of our time, everyone. If you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or sign up for our newsletter to learn about upcoming events. Our next teleconference will be tomorrow, July 20th at 3 o'clock Eastern. And our speaker is going to be MS certified nurse Sherry Binns. We're so lucky that every other month Sherry hosts the same as Dr. Boster, but she's an MS nurse, so it's Ask the MS Nurse, and she spends an hour answering your questions about symptom management. As you leave the conference today, a survey will appear on your screen. We ask you to please take a moment to give us your feedback on this program and your suggestions for future topics, so we can be sure to provide you with the best programs possible and the ones that are most meaningful to you. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Boster, who answers one question after another, barely coming up for air. Have a wonderful evening, everybody, and I hope to see you again soon. Bye-bye.